Testing 5 4 3 2 1 1 2 3 4 5.
Well, good afternoon, everybody. This is the September 2nd meeting of the Quality Committee being called to order. Any citizens to be recognized?
We have no citizens. I mean, we have citizens, but they're not
I
here.
was going to wait to see if you recovered from that. Okay, the next on the agenda is approval of the minutes for June 3rd. Do I hear
Move approval of the June 3rd minutes.
Dorothy with approval? DT with second. All those in favor say aye.
Aye.
Opposed, same sign. Motion passes. All right, agenda item B. And let's see what we're going to do. Dr. Elliott, you're going to present these to us?
Yes, I am, sir. Thank you.
Okay, go ahead.
Thank you, Mr. Chairman. So we're presenting different policies here that you see listed here for approval. These policies are aligned with the activities that we have in graduate medical education, undergraduate medical education, and continuing medical education. These are updates to our policies, as you see item 1, 2, 4, 5, 6, 7, and 8. I'm extracting and asking for approval for archival of item 3, the practitioner on-call policy, due to that being now in medical staff policies and bylaws. So first I'm asking for approval of items 1, 2, 4, 5, 6, 7, 8 of those policies.
Any questions? Do I hear a motion on all but number 2?
I move to accept items 1, 2, 4, 5, 6, 7, 8, moved forward.
Second.
Got a Amanda motion and Dorothy second. All those in favor?
Aye.
And those opposed, same sign. Okay, motion passes. Now we need to,
Second is asking for archival of item number 3, Academic Affairs Policy 2700, Practitioner on Call Policy, as this is already in the medical staff policies and bylaws.
Moved.
okay, Amanda's,
Second.
Dorothy's the second. Any discussion? All those in favor?
Aye.
Any opposed? Motion passes.
Thank you very much.
Thank you. All right, we're on to item 4 now, and it looks like A is PSI 90 and quality scorecard with Dr. Rob Stephenson.
Excuse me. We got one more.
Oh, 9.
9.
See, sorry about that. Sorry, sir.
Oh, you're good. Approved? Okay. All right. So AC 2000 compressed cylinder safety. This is a triennial approval for this policy. I'm presenting this for Adam Lane. Someone trying to talk? Okay. There's no major changes on this policy. It actually had a procedure with it that got approved last year. For some reason, this policy didn't get approved at the same time. Other than that, no major changes on this policy.
Yeah, right.
All right. All right, do I hear a motion?
Move approval.
Dorothy moves. DT second. Any discussion?
For the record, sir, that is Michael Miller who is presenting on behalf
Okay.
of Adam Lane.
All right, Michael. All right, we ready for a vote? All those in favor, say aye.
Aye.
Opposed, same sign.
Okay.
Motion passes.
Exceptional job, Michael.
Yeah.
Tell Adam that very thing.
Now we're ready for 4A with Rob.
There we go. All right, we'll start with our quality scorecard. So PSI 90 is our quality pillar goal for 2021. It's been a tough year, largely because of COVID. As you can see, we've had a pretty substantial increase in hospital-acquired pressure injuries. One of the interesting things around the country is organizations have been reporting up to 400% increase in HAPIs associated with COVID. And we haven't seen quite that dramatic an increase, but we've certainly seen an increase, and it's been really one of the major drivers. The other one that's a little different than what we've seen in previous years is PSI 9. So PSI 9 there, postoperative hemorrhage or hematoma. And this is actually tracked with the expansion of our plastic and reconstructive surgery service program. And so about half of the, 4 out of these 8 have been associated with major plastic reconstructive operations. So free flaps, rotational flaps. There was one that was in a tissue expander. And the threshold for, a couple of things that are interesting about this. Number one, the threshold for taking a patient back after a free flap or one of these other operations in terms of bleeding is small, right? So if you have a 50 milliliter hematoma, you're going to take that back because you want that result to be absolutely perfect. The other thing, and I've been working with the plastic surgeons on this over the last few weeks because I think there's some real opportunities here, is that they actually give their patients big doses of antiplatelet drugs right at the beginning of their operation. So actually some of these are actually would be definitionally excludable if they were able to code those properly. And they do that knowing that those drugs will increase the risk of bleeding, but they absolutely increase the rate of success for these free flaps. And so if you know, the worst complication that you could possibly have after a free flap is the loss of the flap. Going back for a small hematoma, that's not really that serious in comparison. And so, it's been around that. So I think we've got some real opportunities to improve that, and we're going to put some real focus on that over the next year, and it's under active discussion actually in the Department of Surgery as to whether or not we ought to formally make this an agenda item for the coming year. I'm strongly in support of that, and so hopefully we will see that come to pass, and we'll see some improved performance in that in the next year. But that's a key area of improvement. The other one that we've had our eye on all year, and I've mentioned before, is the postoperative sepsis. We actually have, if we don't get another one for the year, we should be at par compared to last year in terms of the total number of cases. But what we do know is that these cases are associated with frailty, and so there's a big effort going on to try to screen patients for frailty prior to surgery, potentially intervene on them to try to move them from frail to pre-frail or frail to not frail prior to surgery with prehab type interventions. And this is an area of key interest for Dr. Miller, our Chief of Surgery and Chief Medical Officer. It's been an area of his academic interest for many, many years, and so he's very keen on seeing this improve. And so more to come on that as we go into the next year. So this is how we've done. We had a tough spike that was very COVID associated in the winter, and we've had a couple of tough months lately as well associated with these hematomas as well as pressure injuries. So those are big areas of work for the coming year. For the rest of the scorecard, our hand hygiene compliance remains very strong at much greater than 90%. One of the big stories for this year, which I think is just, it's actually mind-blowing. I never thought that I'd ever see the day that we had a colon surgical site infection rate of less than 1. So 1 means you're performing as expected. If you're below 1, you're better than expected. And if you recall, we had this on the AIP goal in 2018, I think, was the year that was there. And it was challenging to move. We did move it, but we didn't get it anywhere near where it is now. So we've continued the attention, the focus. We actually had a little blip of these cases right at the beginning of COVID when some of our processes got a bit disrupted. So this is way back in March, April, May of 2020. And then we jumped all over it, got the processes scrubbed back up, and we're now performing it better than expected. If you look at the calendar year to date, that number is 0.65. So the performance in the last 7 months has been really phenomenal. Hopefully that's sustainable, but we're really excited to see that. The abdominal hysterectomy rate remains good at 0.76. That's also better than we've seen before here at JPS. What's interesting about this group is that all on their own, they have undertaken to put together a whole new SSI bundle to drive it down even more. So I'm just absolutely thrilled to see that level of commitment from the OBGYN service and infection prevention to try to get that even better. We've cut our rate of infection in hip arthroplasty in half year to year, which is really fantastic, and a lot of credit to some really outstanding work being done by orthopedics in terms of getting their patients ready for surgery and doing all the things you need to do to maintain outstanding performance in the operating room. The knees are going very well this year as well, as you can see. Our MRSA and C. diff rates are also very strong. We actually are rolling out new education on C. diff to our physicians to try to prevent over-ordering of C. diff testing in the hospital, because there's some testing that's going on that's still not exactly according to what would be recommended. But overall, that performance is a great indicator of our strong antimicrobial stewardship program here. So the thing that really drives C. diff is inappropriate use of antibiotics, and we continue to perform well in that area. The challenge for the year, as you can see, has been the central line infections and the catheter-associated urinary tract infections. Data that came out just a little bit too late for getting into the board book demonstrates that if you just take the COVID patients out, our performance is as good as it's ever been, and much better than a rate of 1.0 for both. And so that's really exciting. And it's a story I really need to tell our employees. It's very fresh data, but I can tell you they're really trying hard, and this is an indication that they're really trying hard. But you can't stop a hurricane with an umbrella, and what we've been dealing with, certainly has been an unprecedented onslaught on the healthcare system in general. And it's indicators like this that are very sensitive to to perturbations like a global pandemic. So we are encouraged by that. Obviously, there's still areas for improvement. We're still working on it, but it is nice to know that the underlying performance remains strong and people are still very committed to doing the right thing. We will be. I'll try to bring that data back to show you next time so you can actually see it, but it's something that came out very recently. All right.
Any questions? All right, then we'll move on to the COVID-19.
All righty. Well, these slides get out of date. The COVID-19 update slides get out of date within 24 hours of making them, and when you have to put things together for the board book, 10 days in advance, it's very challenging, but the dynamics continue to shift very quickly, and we've had to be very nimble in dealing with the numbers of patients that we've been seeing, as well as the very tight staffing market in North Texas for healthcare. So as you can see, we're back on an upswing in the United States in terms of case volumes. And that's reflected in Texas, which is perhaps a little bit more pronounced. We've been one of the hot spots over the last several weeks for COVID-19. Tarrant County has been a particular hot spot within Texas. We've had quite a bit of surge in cases in Tarrant County. As you can see, we're back up to really levels beyond what we saw in July of 2020 in terms of overall volume. This has been the course of hospital volume here at JPS. So that first peak way back in April, May of 2020 were the inmates from the federal prison where they had a major outbreak. The July peak, as you can see, of course, the big December, January peak where we hit actually a maximum in the hospital of 212. We then had those blissful few months where we were able to work on a whole lot of other things that we needed to work on and not just focus on surviving COVID. And now we've had this more recent surge starting in late July and running through to the present. This slide has changed probably the most dramatically over the last week, and I'm really excited about it, actually. So this is what I guess a week and a half ago, UT Southwestern was predicting for COVID volume here in North Texas. And this was a pretty scary slide, I have to say, because, if it came true, we would be seeing hospital volumes, because what's on the y-axis here is occupied beds in North Texas. If we had surged as high, and the yellow line is if we were to maintain current public health practices, the red line is if we were to go back to pre-pandemic life, and the green and the blue lines are what would happen if we were to reinstitute very aggressive public health measures, masking, social distancing, all that kind of stuff, like we did back in June or July of 20 or October and November of 20. So if this had continued, we could have seen, would have predicted that we might have seen volumes in this hospital 50% higher than we saw at our peak in January. And that's a big number, because we hit 212, so we could have been looking at 300. Well, that would have been very challenging. Fortunately, I just looked at their projections this week, and those big spikes have blunted substantially, such that if we continue doing what we're doing right now, we might get a little bit higher than we are now, but it's not looking as dire as it did a week and a half ago, and that's really, really good news. I sure hope that that is true. The one thing I would say is weathermen are really good at predicting closer and closer and closer to the time, to the limiting case of, sticking out your hand and saying, gee, it's raining, so hopefully the fact that we're getting closer to, the peak of this surge means that they're getting better about their predictions, so we'll see, and hopefully that's the case, but I am encouraged. And what's really changed is that, according to their modeling, that both the self-reporting of masking out in the community and the reports of what people are seeing in terms of masking are going back in the right direction again. So people are beginning to make some adjustments in what they're doing out there. And I have seen this. I've seen a few more masks at the grocery store and stuff like that. So just doing those little things, it can make a huge difference to how our healthcare system will fare during this current surge. So I really encourage people to wear their masks out there. It's very, very, very helpful.
That's a quick question.
Yes, sir.
Do we track the number of patients that are on ventilator, that are vaccinated and unvaccinated?
Yeah, so we've had, greater than 95% of our ICU patients are unvaccinated. There have been a few exceptions. We've had some cancer patients on chemotherapy who have gotten very sick, and some patients on other immunosuppressive regimens who've gotten very sick. But that's not surprising. The individuals like that will have a really tough time mounting an immune response to vaccine. And, and it's really why vaccination has to be a community effort, right? Because, it's not just about whether I get sick, but there are a lot of people out there who can't mount immune responses for a whole variety of reasons, perhaps because they're older, perhaps because they're on medications that can blunt their ability to, fight infections, like people who are transplant recipients, people on chemotherapy, people who have autoimmune diseases that are being treated, like rheumatoid arthritis and things like that, Crohn's disease. And so, those people need all of us to be vaccinated in order to protect them, because their immune systems can't protect themselves.
DT, to give you an idea, we've looked at other hospitals. Parkland now is starting to be able to represent data of the number of people that are in their ICUs and the number of people that are in their facility and the number of people that are unvaccinated. We were able now to get our data that we feel very confident that we can do that, and we started doing that today. So
Actually, the 95% is pretty much in line with another large hospital systems, at 96 I'm looking at.
It is. So we will be very fair. It's not a political statement. It's not an editorial comment. It just is the number of people that come into JPS. These are the people that are vaccinated. These are people that are not vaccinated, and just reporting that straightforward. And that's what most hospitals are going to. I just feel really good that we're very secure about the data now.
Yeah, we were limited a bit for a while because there's a certain amount of self-reporting that's been needed previously, and now we've found ways to actually integrate with, the real data out there, and so it makes it a much, much more solid situation than we had previously.
Is that increase the risk for employee that already vaccinated and
So, I mean, the challenge with Delta is that you can get COVID vaccinated with Delta. You're very much less likely to go to the hospital or go to the ICU or die. Much, much less likely. It's still very protective in that regard, but you can get it and you can spread it. And so, it's still very important in the hospital setting for people to maintain, high levels of precaution against these things. And we've actually taken on the OSHA standards here for managing COVID and suspected COVID patients with, everyone's in N95s. Everybody must wear eye protection. Everyone must wear gowns. Everyone must wear gloves. So that's very, very important to protect our staff and all of our team members who are engaged in that care. So.
Okay.
All right.
Any more questions on that?
Yeah, I just run through what we've done. We've hugely scaled up our outpatient case management program. We are now managing over 300 patients with COVID through our outpatient case management program. That's the biggest I believe it's ever been, and we have about 80 patients on home oxygen on that program. So right now we've got about 130 patients in the hospital with COVID. We could have 210 if we didn't have that program, because certainly all of those oxygen-requiring patients without that program would be in the hospital. So that's been absolutely, once again, another round of COVID, and that program has once again allowed us to get through this very, as well as you could possibly imagine. So that's been a giant thing for JPS over and over again. We closed elective surgery at both the main OR and our ambulatory surgery center in Arlington. We actually are now using, once again, we did this back in January, but we're doing it again. We've reopened pre-op holding as an intermediate care unit. We've reopened the COVID-19 adult behavioral health inpatient unit, and we currently have about 10 patients on that unit. We are prepared to reopen the AHU as a COVID-19 unit, but so far we have found it more advantageous actually to continue managing our COVID patients in cordoned off areas of the regular ICU, as well as two of our other intermediate care units, and that has actually been more efficient for care. And so as long as we can continue to do that, we want to do that because it's been better for our patients and for all of our teams. As of the printing of this slide, we had received 28 RNs and 5 respiratory therapists from the state. We've continued to receive more, which has been helpful, although not enough to completely alleviate the stress and strain on the system, but it has, every little bit helps, so we're very pleased about that. We've deployed available non-clinical nurses and others to support clinical operations. A bunch from my quality division have redeployed and helped out in a whole variety of areas, including Sean over there, who helped out in the laundry, so we've appreciated that. We've redeployed our critical care surgeons, our advanced practice professionals from the surgical ICU, some of our nurse anesthetists, as well as now some ED physicians to help out caring for our COVID-19 ICU patients. And we're now planning for booster shots for all, and right now actually administering third doses to immunocompromised individuals. We've now given over 100,000 doses of vaccine here at JPS, so it's been a tremendous contribution to the community effort to deliver vaccine to folks. So really, once again, a phenomenal coordinated response from everybody to helping get through the latest surge of the pandemic.
Question for you, just out of curiosity, where do we get what does the state get 28 RNs from when we're having so much trouble just keeping the staff in our hospitals with nurses?
So this is an area where really everyone's struggling. Lots of reports really all across the United States, but particularly in the areas that are hard hit, of nurses walking away from the profession in general, because it's just been so taxing. This pandemic, if you really want to get to it, has been borne most heavily by nurses and respiratory therapists. It's really been tremendously stressful. And it's one thing when you you got a big disaster or something like that, everybody pitches in, everybody wants to help, and that's great, and you can do that. And maybe you can do it again, but we've had to do it again and again and again and again. And that's not just JPS, but really all over Texas, all over the United States has had to do this multiple times, and it's been very challenging to find people. Of course, then there's also been the disruptions at home with, folks having to monitor kids at school, been remote schooling through the last year and all this stuff. So a lot of people have drifted out of the profession. These nurses have been provided through the RAC, which is a regional state resource, and they've been bringing nurses in from really all over the country. The one place they're not supposed to bring them in from is Texas, because we need, all the hospitals in Texas need their nurses right now. So we've been bringing them in they've been bringing them in from other parts of the country, and they've been, we ask, they give us less than we ask, and then we ask again, and they give us a little bit less than we ask. But it's gradually we've gotten more and more, and it's helped. So, but huge help from nursing leadership, from HR, onboarding these people quickly, getting them here, all that stuff. So it's been a big effort, but it's helped, and so it's been very successful. Robert, I don't know if you want to add anything.
Yeah, to give you an idea, Zim, you can have internal problems finding nurses, but those nurses that are in those are going to places for a short period of time and moving on, going to another place, and they enjoy that work. And they enjoy, in essence, that firefighting. So it's a different breed and a special form of a nurse that does that. And in this crisis, they like it. To Rob's point, we're bringing them from all over the nation to come in. Some have military backgrounds, some have been part of the military, just retired from the military, and they come in and do that. We have found with the 30 that we got 2 weeks ago, although we were grateful and very, very thankful, as Rob said, it was way shy of the mark that we wanted, but everybody is not getting what they want. The challenge that we had is within the first day of the 30, I think 5 left, because sometimes it's hard to understand the acuity levels at JPS. We can tell them that. We can tell them what our emergency room looks like. We can tell them what our ICU looks like, but until they see it, they can't do what here in just a minute, you're going to get a report from 3 incredible people down from the ED and other places that help us. And the people that come in don't understand what those 3 women do. And it's pretty amazing. So we lost 5 within, I think, the first 4 hours because of what JPS and who JPS is. So when those 3 ladies come up, you'll know how powerful they are.
And the other thing you don't always know is what the skill set's going to be that you're getting. I mean, we've had nurses who haven't passed their EKG interpretations and, a variety of things. So, it's, and then your total yield, you get 28, your total yield may not be, some may leave, some may not have the skills that are required or whatever, and so you don't quite get the full yield each time. But again, when you're really trying to get through a challenging situation, every little bit helps, and you appreciate what you get.
Yeah, it was just curiosity, because you would think that maybe these would be coming from other hospitals, but kind of what you're telling me is they're just out there and they're on call, and when they're not called, then they just wait for the call, huh?
Well, yeah, well, they're typical, almost firefighter-like, and they go to where that call is, and they'll leave here and they'll go to Houston, and they'll leave Houston and they'll go to Detroit, and they'll leave Detroit and they'll go to New Orleans if they can get in. And it's a challenge. It's just that core of who that person is.
So they're contract nurses, basically. Okay.
Yeah.
All right, any other questions? Okay, Rob, thank you.
Great, thank you.
Okay, next on the agenda is patient experience with Laura Burnside. Hello.
Hello. Thank you for having me here this afternoon. My purpose in being here is to share our most recent information regarding patient experience. And just as with many of the things that Rob just shared, nationally we are seeing a decline on the inpatient side of patient experience. JPS is following that trend on the inpatient side as well. So you can see that year to date, based on a comparison group of every hospital in the country, we have 2 domains that are performing at the 75th percentile or above, and that would be considered top of the country. Now, we have the ability to carve out a subset of that benchmark and compare ourselves with safety net hospitals around the country. And when we do that, we actually achieve 5 domains when we compare ourselves with like hospitals in the 75th percentile or above. The outpatient situation remains pretty much like what you've seen the rest of this fiscal year. The clinics continue to perform at stretch, and this data is inclusive of all of our inpatient visits, our telehealth visits on video, and also our phone telehealth visits. And the last bit of data that I'll show is the additional surveying that we do for areas across the network. So we actually survey all of our patients when they come through our doors. So this information includes our emergency services, our urgent care, our outpatient surgery area, and all of our behavioral health areas as well. And to date, we've received about 40,000 surveys. So all of this data is inclusive of that 40,000 voice of the customer. I'm happy to answer any questions.
Any questions?
Yeah.
Go ahead. No, you go ahead.
You're gonna have to decide that. Remind me again how they're filling out the survey. They're getting called, right?
So it varies. So on the inpatient side, we actually do a live phone call to patients, and we have found that that allows us the largest return based on the population we serve. For our outpatient surgery area, they actually get a live phone call and an e-survey. And then all the other areas, they are e-surveyed within 24 hours of their visit, and that's text or email.
Okay. And I know we talked about this last year, language inclusivity. What percentage is Spanish speaking on the surveys?
I don't have that information, Amanda, but I will get that for you.
Perfect.
We do have that. Interestingly, our non-English speaking populations actually have a higher perception of the care that they receive here. So it shows our interpretive services actually really are doing that wonderful job of, creating that bridge between cultural gaps. So,
Good.
But I can send you that information as far as how
Another thing that will
many.
help you is Laura is coming before the full board. You'll see it when the agenda comes out on Friday. Laura's coming before the full board with a little more in-depth look at not only language services, but what we're doing with our surveys and what's now being expected of us and what's required of us, what we can send and what we can't send. As a public hospital, we get it a little more challenging from the requirements, which I find, well, it's just different. I probably should not make any comment. But, yeah, I did.
Yeah, you did.
So you'll get a little more in-depth from Laura when we have our Thursday meeting as well.
Yeah.
And my question was on your organizational goals. On setting up our thresholds and targets, what are we measuring those against? I'm not sure I remember what we set that up.
So for inpatient, we are, which ones are you?
To
The last page?
the last page that you were talking
Okay.
about them.
These were actually, we received assistance from our vendor on where to set the threshold target and stretch based on national averages.
Oh, okay, all right, that was my question.
And then we followed our methodology of 1% increase.
Oh, okay, all right.
Okay, any other questions? Thank you, Laura.
Thank you so much.
Okay, next on the agenda is Innovation Corner, and we've got a crowd coming to help us on this one. Dr. Jessica Kirby, Kathy Watts, and Jessica Algor.
Good afternoon.
Good afternoon.
Thank you for having us. I am Dr. Jessica Kirby. I am the medical director of the JPS Emergency Department, and I have been the physician champion for our sepsis committee for the past 4 to 5 years. I am thrilled to be here with Kathy Watts today. She is our sepsis coordinator to talk a little bit about our program. We have come leaps and bounds from where we were 5 years ago in regard to educating the community about sepsis, to meeting and exceeding our goals. So time and time again, Kathy has led the committee to do incredible things, and I'm just so proud to be here today for you to see the data. So go ahead, Kathy.
All right, I am Kathy Watts. I'm the sepsis coordinator for JPS. Behind me is my partner, Jessica Aguilar. We are not dressed in business clothes because we are supporting the deployment to help with the clinical aspect. Both Jess and I work down in the ED today. It's been 14 years. It's been a while, so. All right. Our other champion for our program is Dr. Jocelyn Z, and she is our intensivist in the ICU pulmonary doctor. She is not able to be here because she is working today. So, next slide, please. Or am I in charge of the slides?
You are the slide.
Okay, well, let's just go with that.
But it is cool to walk around during your day telling people to do things that aren't there. That's usually what I do, Kathy, so I'm excited to see you do it too.
Well, I noticed someone bought you your glasses, and I'm thinking, yes, I need the glasses. All right, this is, as you can see, our program leadership. It starts at the top with Wanda Peoples and comes right on down. Our program reports directly to Elizabeth Rogers as the Director of Clinical Services. This slide is our program overview, and the mission of our program is to improve sepsis care for all patients at risk for sepsis in our community. I will tell you the last 18 months have been a huge challenge with COVID. We have partnered with JPS Communications to help educate our community using Facebook and Twitter. Communications does, but we help them, regular posts and tweets about sepsis and when the members of the community should come to the emergency room. You know, so many people are afraid to come now, and we want to make sure they understand when it's appropriate to come. Beyond that, the sepsis program collaborates with the DFW Hospital Council. For community outreach, we offer monthly programs for professionals as well as for those in the community. Last September, the sepsis team, Jess and I, were able to participate in the Human Side of Healthcare radio broadcast to do some education for the community as well. And Jess, in July, worked at the Senior Synergy Fair, where we were able to reach about 500 people. So what is sepsis, for those that don't know? Sepsis is defined as it's the overwhelming reaction of a body to an infection. It's not just the infection itself, it is the body's reaction to that infection. Sepsis that's left untreated will cause organ damage, and it can cause death. Statistically, for every hour that a patient is not treated for sepsis, the chances of dying goes up by 8%. So the first hour at home, I'll take 2 Tylenol, 8% chance of dying from sepsis. 3 hours, you're now at 24%, and so on and so forth. Therefore, when sepsis is recognized, it's very important for them to be treated, either family practice, if we're at that point, or come to the emergency room. Originally, our program was certified through the Joint Commission in sepsis. We are, again, open for a window for a Joint Commission survey. We have been, and I don't have a recent update, but most recent that I'm aware of, we're one of 2 safety net hospitals in the United States to have that designation from the Joint Commission, and we're very proud of that. Departments that are impacted here at the hospital, I will tell you, it is every department in this hospital. Approximately 85% of patients with sepsis come from the community. So they come in through our emergency room primarily, although we do have cases that originate in-house, but we are impacting the lab, the nursing staff, the providers, surgery, all up and down the line. It goes from the newborn baby, the neonate, all the way up to, people much older than myself. I guess the other thing that I would say about this is that sepsis has the ability to greatly impact the life of those that it affects. Sometimes we have patients that are not treated for 1, 2, 5, 8, 10 hours. Those patients can be here with us in this hospital for weeks and months at a time. we can get them through that acute phase. However, the side effects linger. And so they use our community health, they use our resources out there. So they can be very taxing once they leave the inpatient side of the hospital. One more little agenda item there. Within 90 days, 90-day hospital readmission is approximately 30 to 40%. So it carries a high readmission rate with it. Next slide, please. Okay, this is an overview of the consults. It's hard to see on this graph. However, this information starts in August of 2018 and comes up to the present, and I believe this past July was when I ended it. The sepsis department here at JPS has had 2 people within that department. Currently, it's Jess and myself. We've always had 2 people. When we first started, as you can see, our consults, 70, 80, 90. The last months, we're headed up towards 300 consults a month. So you think, what is a sepsis consult? A sepsis consult is placed by either a nurse or a provider. Most often, it's our ED providers. And they enter an order. It comes to Jess and I. We take a look at that chart. We review that chart for all kinds of information. We review it primarily to make sure that we gave the best evidence-based care that we can, and to make sure that we've met the metrics for both the Centers for Medicaid and Medicare, CMS, as well as the Joint Commission. When those metrics aren't met, then we reach out to our physicians, we reach out to the nurses, and see what happened in that process, that we're not meeting that expectation. And then we try to move forward from there.
May I say,
I beg your pardon?
may I ask a quick question here, since I'm
Absolutely.
not on the clinician side?
Yes, sir.
The number of consult goes up. What is it telling us? Because is it we know more, so we ask for more, that we have a department, or we actually have cases that fit into the criteria?
A little bit, if you'd like.
Go right ahead.
So one of the hardest things on the physician side is to have the physician think about sepsis. And for a long time, it didn't even cross their radar. They didn't even think about it. When they think about it, we encourage them to use our sepsis order set, and in that is the consult order. So when we see that number going up, we see that as the physicians are recognizing the symptoms and signs early and using the order set. What we have found is as we increase use of the order set, we have increased quality data or improved outcomes. So I would say that as we see more consults, you're using the order set more and patients are having better care, better outcomes. The other advantage to the consults is that if it's real time, she can help guide the physician. So if I put a consult in and she sees that I have a sick patient, she may come down and say, hey, Kirby, I saw you have a sepsis patient. Did you do the bundle? Did you get the antibiotics? So it's a real-time opportunity for her to intervene to ensure that patients get the care they need.
So should we be looking at this as a combination of more education and then more cases that fit into it, or?
That's
why
really,
I'm struggling.
that's a hard one to break out, and I totally understand what you're asking. It is a matter in part of education. It is also a matter in part of the rise in our COVID cases and the things that we're seeing just in general in the community.
And the reason I'm trying to ask this question, is there an opportunity down the road to look at this and kind of predict or make it that as part of the standard of care when you see certain indicator that pops up, that this should drive this behavior, and you should be looking at that, because otherwise it's just going to continue. If they're not exposed to it, they don't know it's there.
Okay, absolutely. And a large measure of the challenge is that this is a teaching hospital. And every July, we bring in a whole new group of physicians that really know very little to nothing about sepsis. And we continually do that re-education and that refresh, with every month that passes, because not only do they come in new in July, but every group changes over every month.
Because sepsis is one of the top 10
Absolutely.
items on the population health, and I'm surprised that
Yes.
that's why I'm trying to see, how do we formulate certain indicators so that it pops up and guide people toward more standard of care if there's a certain things that we're looking at.
Well, I think you're going to talk about a little bit of that in the end, right?
We're going to talk about some predictive analytics and a couple of other things. So,
You're on the right track.
Great question. Great question. Any other questions? All right. So, let me back up here. Make sure I didn't skip a slide. This is our scorecard. And as you can see, let me back up one more time. So this scorecard represents our Joint Commission disease-specific metrics. The sepsis program is really governed by three things: evidence-based practice, the best practice that is available out there. We are governed by the Centers for Medicaid and Medicare because they have certain standards that they expect that we will meet in order to be reimbursed. And we also have metrics that are put forth by the Joint Commission. This particular scorecard are our Joint Commission metrics. As you can see, the scorecard is primarily green, except for mortality. Mortality has been our biggest challenge this past year, and in part that has been due to COVID. However, given the fact that we have had COVID for 18 months now, for our scorecard to be green, that speaks very highly of the care that we're giving here, the physicians that are working here, and the staff that are taking care of these patients. Down at the bottom of that scorecard are the 4 specific metrics that we are measuring right now, which is antibiotics within 3 hours of diagnosis of severe sepsis or septic shock, the 3-hour bundle, which is a complete bundle including IV fluids, antibiotics, lab work, et cetera, and order set use, which Dr. Kirby in the ED, that is measured from there, and our mortality rate. It is part of PS 90, is that, it is included in that measure, yes.
The other side, when we start moving for more value-based.
As far as community being able to see this measure and how well we're doing? Oh, that's an excellent question. You know, that's an excellent question that I do not have a good answer for, as I do not deal with that part of it. However, let me write that down.
It is,
Well,
I can chime in.
absolutely.
We'll share with you.
So it's not currently part of value-based purchasing. It's certainly worth considering, and it's up to CMS. Now, all this stuff is actually required by CMS. It's the only of the disease-specific programs.
This is our Joint Commission metrics.
Right. No, but I mean, having a sepsis program and doing certain things
Yes.
is actually a CMS,
Yes.
priority, and it's, of all the disease-specific programs, it's the only one where that is the case. So there is a lot of focus and attention on this. I think what'll be interesting is the next couple of slides, which benchmark us against others, both in Texas and the rest of the country, and I think you'll find that information very interesting.
Right,
Where we're going to turn DT, and
Right.
combination, yeah.
I've noticed.
And I'm trying to
You
work
can't be
around.
measuring that with a white male, right?
Correct.
Because the mass, muscle mass. So you have to adjust that by 15.9% to be equal to, otherwise you set up all kind of alarm.
right. And I'm actually going to address that here in just a second.
Okay.
We're going to talk about that just a little bit. One more thing that I'll add to what Dr. Stevenson said. In order for us to pass the Centers for Medicaid and Medicare and be reimbursed for sepsis care, our physicians, our staff have to meet 64 standard points. If we miss one of those standard points, then we do not pass that measure. So we actually do quite well, and that is reflected in this slide. On the left-hand side, this is JPS. This information is from the Medicare.gov website as of July the 21st of this year. This benchmarks us against the state of Texas as well as the national average for sepsis care. So we are at 70%. The state of Texas is at 64%, and the national average is at 60%. So for a safety net hospital, we feel like we're doing quite well. And I am getting to your question. I am almost there. Any questions about this slide? All right. So this will in part answer your question. This is a work in progress. Right after COVID began, this was a process improvement. We do a lot of process improvement, from patient education to printables to staff education. We do a wide range of improvement. This past a year ago, actually, June and July, we partnered with the emergency room to create a database. There is not a national sepsis registry like there is a trauma registry. There is not a state registry. So we created our own here at JPS. Prior to the implementation of what I'm going to tell you about, everything that Jess and I did that was done in the sepsis department previously was done using pencil and paper and put in a big file drawer, never to be seen again, and the information was not usable for any kind of research project, to look at trends, or to do any kind of benchmarking. The ED and the sepsis department, we worked together to build a database. We moved from pencil and paper to complete online in this particular database, entry of information. As you can see, the hashtag or hash mark, the red, long, big mark there, to the left of that was kind of where we were with our Centers for Medicaid and Medicaid information. As far as meeting the metrics, we were at about 70%. Once we implemented that database and we could really see where our trends were and begin to track it, we've been able now to move that mark up, and we're starting to go forward and raise the benchmark for ourselves just a little bit. And we hope to continue to do that as we move forward. The database started out being actually quite small. We have spoken with the IRB here at the hospital, as well as a couple other partners, to see what information we need to expand that database to, including ICD-9 codes, race, ethnicity, male, female, the whole 9 yards. And as we begin to move forward, we collect that information anyway. It'll be an amazing research database, and we're getting there with it.
And I'm assuming the registry is NCQA compliance, that thing, or is that something?
NCQA doesn't have a registry for sepsis, not that I am aware of. The state of New York has a registry. There are several states that have registries for sepsis. There's not a national one. Texas does not have one. And there is not an agency that I'm aware of that has one, per se, that we could feed into. Stroke has one, get with the guidelines. AMI has one, sepsis does not, despite the fact that sepsis is very costly.
Are you familiar with DAV?
DAV, I am not.
Data aggregation, validation.
Okay, that is familiar.
You may want to take a look at that, so that as you take on information from a subsystem, different EMR, other stuff,
Okay,
so that it stay with the standardization, so that you can use it for other purposes down the road, including research and all that stuff also as well. Because otherwise, there's no standard out there. You might as well adapt to certain standards so that you can
correct.
adapt to it a lot easier.
Okay, thank you. The future of sepsis. We have a lot of things planned for the future. We are using our database, for instance, to enter our projects into poster presentations and fairs. Jess and I were able to win a second and third place in the most recent quality fair here. We've entered into the DFW Hospital Council. We're using that information to help educate not only here, but in the community, and to highlight what we're doing here. Predictive analytics is going to be a big one for us. Historically, we have not utilized the predictive analytics within Epic as fully as we could. And moving forward, we have several items that we are working on, including a sepsis detect score and a deterioration index. And we are moving forward with that build. It's actually been built. It's a matter of moving into the education part of it. We're continuing to work on the database to enhance our research. And we are working very closely with our clinical documentation people to make sure that JPS receives the reimbursement that it should for the care that we provide. And that's all I have. Do you have any other questions?
Any other questions?
I will say that when we have a survey, Kathy is pretty amazing about going through the survey. And we've had so many successful sepsis surveys, and to be one of 2 hospitals in the nation that have the program and be certified is pretty amazing. So her and Jess do an incredible job. And Dr. Kirby, not only this, but 18 other million jobs that she has, and she still outperforms her husband who's in the ED too. So.
I got a good team.
I know, right? It's amazing. Thank you all very much. Thank you.
Thank you. Okay, that pretty much is the agenda before we go into executive session. I just want to say something. My background is nowhere near being medical. The closest I get to that is I married a nurse. And that didn't give me a good experience because she just tell me, get over it. But when I first came to Fort Worth, JPS was not held in very high regard. In the 2 years that I've been here, I found this to be an amazing facility with amazing people. When COVID came along, you were able to adapt, to change, to be able to get ahead of some of the stuff that now is going to be, I think, going to be routine from now on, most of the stuff with internet and whatnot. And so I just want to tell you how proud I am to be part of this board and part of this organization. Thanks to all of you.
Thank you.
Okay, with that, we'll go into executive session.